Test 1 2 3. Test 3 2 1.
Thank you. I'd like to call the meeting to order at this time. And the next on our agenda is the opening prayer, and then be followed by the pledge. Want to come up, Lynn?
Thank you so much. So good to be with you all this afternoon. Please join me in prayer. Loving and sovereign God, we come to you today asking for your guidance, wisdom, and support as we begin this meeting. Help us to engage in meaningful discussion. Allow us to grow in unity as we nurture the bonds of community. In this time of uncertainty, let us be certain in our calling to do our best and to be our best for all the communities we serve. In your holy name we pray. Amen.
Amen. Pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
We have no citizens wishing to speak, so we will continue with our agenda. Next is the approval of the minutes. Are there any corrections to the minutes? Then I'll.
Second.
All right, it's been moved by Roger, second by Charlie. All those in favor of approval of the minutes signify by saying aye. Aye. Those opposed by nay. Motion passes unanimous. Since Chuck is not here today, I will give his report. And the one thing that we have on it is the nominating committee appointment. As you all know, Dr. Weber's final term as chair will conclude at the end of December. So he has asked us to attend to the matter of the board officers in his absence. In anticipation, he has also asked the following board members to serve on the nominating committee, and they have all agreed. So he has asked me to announce the following nominations committee: Steve Montgomery, Ralph Emerson, Charlie Powell. Ralph Emerson will serve as the chair of the committee. Also, in accordance with the term of the bylaws, once Dr. Weber's term is concluded and his seat as chair is vacant, the current vice chair, i.e. Dorothy Debose, will immediately become the chair, and which in turn will cause the vice chair position to be vacant, at which time our current secretary, Mr. Fisher, will immediately become vice chair. Therefore, unless there is any disagreement, the only officer selection that requires referral to the nominating committee is the position of the secretary. Okay, no discussion. Here, no disagreement. We will notate in the minutes that at the end of the current term, the vacancy in the chair and the vice chair position will be filled by the current vice chair and secretary respectively. And in accordance with the bylaws, the board will refer the selection of the new secretary to the nominating committee. We will ask that the nominating committee bring forth the recommendation or recommendations for the secretary to the November board meeting. Any board member wishing to be considered for the position of secretary should submit his or her requested name to the nominating committee. Okay? All right. That concludes the chair's report. Mr. Early?
Thank you very much, Madam Chair. Wanted to go over a couple things with you all. Our construction team and the great work of Angie Morgan and the sort of brainchild of Laura Burnside got together and created, and I thought they did an incredibly great job of it, our Prayer Remembrance Garden. It is just on the other side of the entrance where the flags are in the circle. Right behind there, we had a little bit of space. And what you can do, particularly as a patient here or a family member, there are rocks. You can put the name of somebody special to you on that rock, and you can place it in the garden. And it's a nice area for contemplation. It's a nice area to just sit and take in some hopeful calmness or reflect or remember. And so we had a really incredible crew that did that. Our crew from Employees Assistance Program and Glenda, Leanne, Anya, Shannon. They were all really, really critically important in helping put that together. And then we have a grief support team that's made up of folks from our Employee Assistance Program, our HR department, and our patient relations team really put that together. So when you're walking out of the building, if you walk out the opposite entrance than which y'all usually come in, if you'll go by there, you kind of see that remembrance garden, and I'm really, really proud and pleased with that. Also wanted to provide you a bit of an update. I was asked a couple months ago to go and speak to the Arlington City Council. And I went to Arlington yesterday along with Lauren Poe, our strategic planning team, and went over and met with the city of Arlington and gave them some of the ideas that you all have been discussing about where we are, where our bond package is, what the process is. I communicated to Commissioner Allen before I had gone over there, but the Arlington City Council was really exceptionally nice and exceptionally kind in just trying to figure out where JPS is heading, what we want to do. I thought they were more than cordial and more than willing to understand the process. I told them that we were data-driven. I told them that we would look at data, and data pointed us to a lot of where our patients are coming from and therefore where our need is. Told them that there was a lot that went into that process, and they seemed to be very understanding of that. Also, so it was a good meeting, I thought, and a lot of good discussion and a lot of good questions from the City Council, and I was happy to be there. Wanted to give you all a quick update on COVID. Our numbers, I think we now can say, have been trending down for the past 2 weeks. We've seen that number stay fairly steady for a good 3 months. We've now seen that number begin to come down. Our number today, our census as of this morning, and that census number has probably changed, but we have 71 COVID positive patients in our facility now. If you will recall, we were seeing numbers of 120, 125. So we're pleased with the number coming down, but I will say that this is an organization that has seen numbers come down before. And at least from my perspective as a non-medical person, and that is a very unqualified statement on my part to tell you that I don't think there's an ending date to COVID. I think we've all hoped that on this day we would be done with COVID and we moved on. And I think the variants of it create challenges. And I think you all as a board need to realize there's not a definitive ending date. There is, how do we combat it? And if there is a new variant after the Delta variant, what will it be? How effective or unfortunately how severe will it be? So this organization is prepared to deal with that in the best way possible. I will tell you in all honesty, it's hard not to have fatigue. It is hard to witness the deaths. It's hard to witness what's happening here, and then you have to go home and deal with family members who have COVID, and you don't get away from it. Karen Duncan and I and all the executive team start every one of our mornings at about 6 o'clock in the morning with the beginning census, and that starts your day, and that's just a different world. And so, as I've told y'all before, we have removed ourselves from the politics. This is not a political issue. It is truly who's coming in our door, and how do we help them, and what do we do? To that extent, you all have asked before what our percentage is of the number of employees that have been vaccinated here and how we're dealing with it. We are now at 62% of our employees that have been vaccinated. That roughly equates to about 4,500 of our employees who have been vaccinated. And that is helpful. I'm actually glad the number is at that level. I wish the number were at 100%, obviously. And you know my opinion of that issue, because I know what comes into our ICU, and I know the number of people that are in our ICU are unfortunately the unvaccinated. So it does seem to be really empirical how they go together, straight numbers. So we continue to fight the fight and do the battle, but at least the pressure going down somewhat is nice to know that you have 71 patients, not 110 patients. But every day is really, really challenging. So, yes.
Before you move from that, what are the numbers on the medical side?
That's a great question. I don't have the numbers. The question, Dr. Hurd, was what are the numbers of percentages of our medical team have been vaccinated? And I will get that. There's a chance I'll have that before meeting's up, and I'll get that number for you. I was thinking employees and not necessarily the physician side or the caregiver side, but I will try my best to get that number before meeting's up, and if I do, I'll announce it in the meeting. That's a really good point. So we continue to work on the COVID issues. We continue to deal with all that we're dealing with that. We have had a blessing in that we have had 0 deaths in the last 24 hours. And what we see in our deaths is not the old adage. The old adage was it was somebody usually over the age of 60. It was somebody who had comorbidities. That unfortunately is not what we see now in our deaths. What we see now in our death, the only thing that seems to be the common thread is they're unvaccinated. So it's not necessarily that you've got a list of and I think that gave us, community as a whole, this sort of, oh, I can wipe my brow, it's okay. It's somebody who's really got challenges. It's somebody over this age. It's somebody with a lot of health problems. And that's not the case anymore with our COVID deaths. They don't seem to have that common thread of comorbidities or real challenges. So,
Do we track the fatality rate of the ICU admissions? Do you know?
we do. I don't have the question was, do we track the mortality rate? And we do. I just don't have that sitting in front of me, but we do have that number, and we do look at that. So kudos to Karen and our quality team that compile that, and Joy Parker, who compile those numbers every day. We pretty much have a mobile vaccine unit now. I mean, we move it based on space. So when you all are not here, this is a booster and a vaccination center. We move it to the 4th floor, we move it around, but nobody's going to come in this building looking for a vaccination and not get one. We're happy to provide it for anybody who can come to our facility and deal with it.
Boosters yet?
We are offering boosters. Yes, ma'am. Joy, I saw you sit up straight. Did you want to comment on that?
Anything about vaccines, I stood up straight for Robert.
Yeah.
I was just going to say that today, the FDA is reviewing the data from Moderna, because I know that's been a lot of, the question is, Pfizer has approved for expanded population, and we've still been waiting on the data and approval for Moderna. That should happen today with the FDA. It will get scheduled with the CDC, and once the CDC and then from the state, they give the green light, then we are prepared same day to be getting those shots in arms, because to Robert's point, if you meet our team, they are passionate about making sure that we are vaccinating anyone and everyone. Pfizer will be reviewing data at the end of the month with CDC around expansion to our pediatric population, and we have been planning and are prepared for that expansion as well.
I will tell you on behalf of Joy's team and the work that Joy and the fact of the hard work that Doug Chung has done in this. 32 months ago, none of the people that are actively giving vaccines every day were hired to give vaccines of that magnitude and that nature. So they already had a day job before we gave them another day job. And that speaks to what Dorothy and I have talked about, the kind of stress levels and the kind of, put the stress aside, the Herculean kind of efforts that you really thank your employees to do, because they're not hesitant. Joy gets a team together and they assemble and they're in this room and they're ready to go. And we haven't made mistakes, and I'm really proud of the team. And like I said, none of them came in saying, oh, you're going to be the one giving COVID vaccines. That's just what they do now. And so we've sort of replaced this person with this person and fill in here and fill in there. And we still are doing that with our ancillary services. We're still challenged like the rest of industry and everyone else. Trying to get employees to come in to work in certain categories is a challenge. So we're all doing our part. Mr. Nguyen?
Do we know enough? Because when they give the vaccine, you don't have a choice of what you want. Now, a lot of question around that if they have Johnson & Johnson, can they switch to Pfizer? Or if they have Pfizer, can they switch to Moderna? Do we have any guidance on that yet?
I will give the answer, and then I'll point to Joy, who's again sitting up straight. I'll tell you that we are going to follow CDC guidelines, and CDC guidelines have not specifically come out, unless I'm wrong, Joy, that says you can give a Pfizer shot and then you can give a Moderna booster, or you can do a Johnson & Johnson and give a different type of booster. They have not been clear on that at this point. They haven't come out definitively on that. So what we're doing is if you got Pfizer, you'll get the Pfizer booster. And correct me, Joy, if I said any of that incorrectly. I don't know if press is listening, but Joy, yeah, come up to this mic and say that louder. Robert, I'm not saying anything because you're right. So I am. So I owe Joy lunch and I owe DT dinner. But that is, Madam Chair, my report. And again, if Dr. Weber was here, he would say thank you. So in light of that, the team has really done a lot in the last couple of months in particular, because this variant is strong and tough and challenging. And after almost now going on 2 years, it's challenging. But good job to the team.
All right.
I think Charlie has a question.
Yeah, Charlie.
Dorothy, I just want to say one thing. I'm only saying this, Robert, because like you say, we know how you start your day with staff every day. And you also mentioned you spoke Arlington City Council. I just happened to I got a notification. I know Commissioner Allen and I know DT sitting here. Amanda's not here today, but y'all are actually doing a update to the community here in the next week or so. So, I mean,
yes, sir.
With everything else y'all got going on, I commend again what we're trying to do to tell the public about the bond program and what's happening. So
yes,
to
sir.
DT and to Amanda and to Commissioner Allen and you, with all you got going, I appreciate what you're doing.
You bet. Thanks, Charlie. I
Thank you for
appreciate
trying
it.
to
Yeah, we do. We do
communicate all we can.
a
Thank
good
you.
many of those around the community that have been really helpful.
Good.
Thank you.
Thank you.
All right. Any other questions? All right, then you want to introduce them.
Yeah, what I'm going to do is, as you all know, each month we month, and I think it is hugely helpful if you all have an update on our oncology and our infusion center. Not only the people that run it, but the amount of effort that we put financially, and you, a board, directed us to do to create a new facility. And if you have not been to that facility, or you were only there when we first opened it, I would encourage you to go by again and, one, see how busy it is. And the other joy to that particular building is the amount of smiles that are in a facility where smiles can be hard to find sometimes. The staff down there are amazing. So what I'd like to do is bring Joy Parker up and have Joy introduce our two leaders that make things happen.
All right, so good afternoon. I'll get to a microphone this time, I think. So it's my pleasure to introduce our leadership team at our Oncology and Infusion Center. Dr. Gabosh has been with us as our medical director and service line leader for over 8 years. He is one of the most passionate providers that I've had the pleasure to work with about this population that we serve. Makes himself available 24/7 for not only the team, but the patients that we treat. His job, he oversees and partners with Dr. Catherine Sorley, who just received her doctorate, but they partner together to provide care for medical oncology, for radiation oncology patients, for our palliative care program, and then, of course, also for our survivorship program. And so they provide a great comprehensive care to our community. So with Dr. Gabosh, again, come on up, Dr. Gabosh, and his right-hand man, Dr. Catherine Sorley. I say doctor because she's a nurse of 30 years and just received her doctorate of nursing practice just this last month, I believe. So we celebrated via Zoom. And so, yes, sorry, I took the chair so I can get up. And she is celebrating a year with us, but again, over 30 years of oncology and infusion nursing leadership experience. So a fabulous team, and I will turn it over to them.
Let me, Dr. Gabosh, before you start, let me tell you one thing. Dr. Gabosh has as you can imagine in oncology, an incredibly busy schedule. So trying to figure out how to schedule him to fit the board's agenda and fit timing was really, really tough. So we called him and said, can you be at the board meeting? And he said, sure. And we were a little bit curious as to how he had the time, because he didn't even ask when it was. He just said, sure, I'll be there. The reason he has time today is he's on PTO. And so that's the kind of guy he is, that when he's on PTO, he comes before the board and presents. And thank you. And I know you won't appreciate me saying that, but I've already said it and you can't stop it now.
Thank you.
Thank you, Dr. Kabash. Thank you, Katie.
It's my pleasure to be here, and I would like to thank the board for their support of our cancer program. Really allowing us to move to the new cancer center in May of 2019 was a godsend. I cannot imagine how we would have treated our cancer patients in the old building with social distancing, moving the chairs away. It would have been a nightmare. So that was a godsend, and thank you for your support. So I'm really happy to talk about our cancer program, about what's happening at the Oncology and Infusion Center, and about all the great work that our staff are doing over there. So as I said, we moved to the new building in May of 2019, and when we moved there, our first vision was how can we make our patients be as comfortable as possible going through this difficult journey. We've all had loved ones or friends who were touched by cancer, and we know how hard it is to go through that. So add to that some social determinants of health, patients who are homeless, patients with no family support, and you can imagine how their journey is shaping up. So we tried to bring all the services under one roof. We thought, okay, if the patients are going to come to the cancer center, let's bring the providers together around the patient. And we had great support from all the physician services. So we were able to have medical oncology, radiation oncology. We were able to have surgeons present there at the cancer center 2 days per week. We were able to have breast surgeons there, plastic cancer surgeon there. We were able to have head and neck surgeons rotate through the cancer center. And we also added additional services. So we were able to have an urgent care physician available to our cancer patients, avoid them having to go to the emergency room. As you can imagine, with COVID, this put a drench into all this. So our idea was to have patients with cancer who have a fever just come to the cancer center, get treated, and be able to go and be treated at home, not needing to be in the hospital. Where first thing we had to do with COVID is we have to screen patients at the door for fever. So now if they have fever, they cannot come through the doors. So we had to adjust and fix our plan. And go back a little. So again, these are all the services that are available from a physician standpoint. Surgical oncology, neuro-oncology is a unique program we have over there. We have a board-certified neuro-oncologist. We have a neurosurgeon that also rotates through the cancer center. Cancer survivors, we have a family physician, doctor at the cancer center that takes care of the long-term need of the cancer patients when they're done with their treatment, dealing with post-treatment complication, allowing them to get back to their routine medical care. We added psychology clinics to the cancer center to support our patients, and again, head and neck surgery. To be able to find all these physicians under one roof, you're going to need to get out of the DFW area. There's nobody in the area that really gives all these services under one roof. They might be in different buildings across town, but we're able to do all this in one parking spot and allow the patients to get all their visits during the same time, which is great. So we also worked on some community outreach. Our goal is to try to help our primary care physician, our community partner, and try to prevent cancer if we can, or help them detect cancer earlier. My goal is for cancer patients not to need the cancer center, meaning get detected earlier, get treated, and not need chemotherapy, not need radiation if possible. So we work with a multiple community group on prostate cancer. This is an event that's really close to heart to Commissioner Brooks, so we partnered with him with Moncrief on the prostate cancer event every year. Colorectal screening, we help our community help with mobile mammography. We look at the data, see where do we need to target, which areas do we need to target for our mobile mammography. And then there's a lot of work going on in primary care with smoking cessation, preventative health, and we're always happy to participate in any community events, whether they're virtual or in person. And that's something that we always mention to our primary care physician is don't think of us as cancer doctors sitting at the cancer center waiting for the cancer to show up. Let us help you get out to the community and explain to people how can they prevent being my patients. That would be our best goal. Yes.
BT, turn on your mic.
Solution good enough to be able to provide?
Yes, the mobile units we use all have digital mammography, so it's almost similar machines to the one we use in the building, so the quality is excellent. If patient needs a diagnostic procedure like a biopsy, then they'll have to go to our women's center to get it done. But for screening, it's excellent.
Thank you.
With all these challenges of patients' care, we were able to have multiple quality initiatives. We just got our accreditation from the American College of Surgeons. We got 3 years accreditation, we were notified last month about it. The American College of Surgeons looks into 38 different quality measures for the cancer program. And that goes from everything from the surgery to the pathology to the chemotherapy, radiation, and make sure that the program meets all these quality requirements. And we did get a 3 years accreditation, which we are very proud of. We continued our multidisciplinary tumor conferences. We have to adjust and move them to Zoom. And I have to say that attracted more people to these tumor conferences. Now we're seeing some primary care physicians get on these calls whenever we're presenting their cases, which it was hard for them before to just come to the cancer center or to the hospital to be at these conferences. As you know, we partner with some local radiology places to get our PET scan done. And that created a challenge in the past because they didn't send us the images on time. We'll have to request the CD to review it at tumor board. We were able to partner with them and talk to them about embedding these PET scan results directly into our EMR system to where they're available to everybody within our network. So that was a big win. Behavioral health clinic at the cancer center was also a big win. As you can imagine, dealing with cancer is stressful. Dealing with COVID adds more to that. So we were able to provide behavioral health clinic in person and virtually to our patients. Urgent care clinic, again, the goal initially was to have this in person, like a small urgent care at the cancer center to give fluid, gives antibiotics. Because of COVID, we had to readjust, and now it's a virtual urgent care clinic. So if a patient's having sore throat, fever, he can get an appointment, be connected through video to one of our urgent care physicians, and hopefully try to solve their problems and not need to end up in the emergency room or need hospital care. And finally, we got rid of the last shred of paper we had at the cancer center. We used to have the patient sign consent form for chemotherapy on paper because it was too complicated, too many cancer types, too many chemotherapy drugs to be able to have an e-consent. But we work with our IT team, with our community health, and we now are all fully e-consented, and everything is electronic. So with that, I'll move to my partner, Kitty, so she can talk about the support services available at the OIC, and then I'll be happy to answer any questions.
Thank you. All right, well, as Dr. Gabash alluded to, our patients take a lot of care. They have a lot of things going on either with their cancer or they've got a lot going on at home. So as you can see, this is kind of a representation of our team that it takes to support them. So whether they need psychosocial needs, whether they need housing, food, all those kind of things, we have staff in place to try to meet those needs on a daily basis and help ensure that they can concentrate on their healing and actually hopefully beating cancer diagnosis and going into long-term survivorship. We also partner with our community resources to help provide some of this support. So UT Southwestern provides our genetic testing and counseling for our patients. They do that. They can do it in person, but they do a lot of that via video and phone conferences. We partner with Moncrief Cancer Institute to meet the needs of our breast and cervical cancer care patients who are Medicaid patients. They have specific funds and dollars set aside to help those women with either, prescription dollars, resources for utilities, etc. And then the National Breast Cancer Foundation actually funds our Breast Navigator, who is focused on providing breast cancer patients with the many needs that they have, whether it's support groups, questions, education, resources in the community. Many of them have young families, and so they need a lot of psychosocial support. The American Cancer Society has been awesome in helping us with transportation needs. Many of our patients do not have rides to the cancer center, and if they didn't come or have a ride, they would not get their treatment, and then the outcome would not be favorable. So they provide gas cards, they provide bus passes, and they provide Uber Health rides for our patients. The colon cancer screening, as Dr. Gabash mentioned, they also provide coverage for that. We are partnering with the Fort Worth Adolescent and Young Adult for a social worker that specifically is dedicated to that age group. That 15 to 39-year-olds, they struggle with that diagnosis emotionally as well as physically. And so there are a lot of resources available to them, and that social worker is dedicated to helping them find those resources. Cancer care services in the community, they provide a lot of our support groups for our patients. They provide emergency funds for utilities, rent, prescription assistance, et cetera. So they've been a great partner for our patients. And then recently, we partner with the Fort Worth Food Bank to be able to provide on-site groceries for our patients. So we do house a sack of groceries that if a patient is assessed, which we assess all of our patients when they come in for their visit, to see if they have immediate needs, and if they do, then we will send them home with groceries for the night, because we want to make sure that our patients' nutritional needs are met, because it's very important for their healing. So COVID-19 has definitely had an impact on cancer care. We have done our best, though, to stay fully operational. We have been open through the whole pandemic. We have been open from 7 in the morning until 6 o'clock at night, making sure that those patients had their needs met. Many of our patients want to be seen in person, but for those that we could, we did utilize telehealth and phones to be able to help connect with our patients, get them their test results, or be able to assess what was happening with them for symptom management needs. We did allow some of our staff to work from home. Cancer Registry in particular, they're able to do that. The rest of our staff, mainly because of the very close emotional and psychological support that they provide to the patients, were in person every day, struggling with their own worries and concerns about COVID and it being exposed to it and taking it home to their families. But many of the oncology staff rise to the occasion because they recognize that this is a calling and that the patients need them. So they were willing to come in and be there every day. And then additional infusion area was needed because of the spacing of the social distancing aspect of providing care. And so we do appreciate the board for providing some additional funds last summer to be able to expand our infusion area for a few more chairs. So we were able to put 5 more chairs in another space and be able to take care of the same volume of patients. And actually that volume is increasing and not yet compromise any of our patients or their treatment plans. Patient volume, as I mentioned, did dip a little bit in the beginning due to our other clinics being closed, primary care, et cetera. And our patients were still being seen, and we were trying to provide that closure of that gap ourselves. But, you know, as things have gone on and our primary care clinics have opened up, it's been great because now our patients can seek that care that they need. And we are seeing our volume continue to rise back up prior to pre-pandemic volume. So this year it does look like we are going to be very close to our numbers that we completed in 2019 and 2020. Preventative care, as I mentioned, has been a challenge, but it has been good that our clinics are opening back up so we can make sure our patients get the resources they need. And I'm sure Dr. Gabash would mention this as well, that our patients we are seeing today and being diagnosed are actually being diagnosed at later stages than we were seeing them. So we have backslid a little bit because of the pandemic, but certainly we are doing our best to play catch up.
Yes, and this is true across the country. It's about 20% increase in the stage of cancer. So patients who would have been detected at stage 1 or 2, we're seeing them at stage 3 or 4, unfortunately. Yeah. Yeah.
DT, turn on your mic.
Yeah. It's a combination of both. In 2020, with the start of the pandemic, or the screening facility, mammograms unit were closed, colonoscopies were put on hold. So we went almost 6 months without any screening test being done, not at JPS, but at the community as a whole. So this is being called the new cancer pandemic of 2020, and everybody is struggling to deal with it. But we were fortunate in that our primary care partners and our screening efforts were restarted. We were among the first to restart these efforts. I'm sorry, I couldn't hear.
Atlas Health?
Uh-huh.
Are you guys working with them to do any activity there?
No, we'd like to know more about them.
Organizations that have funding from other foundation, charity, and they provide assistance to cancer patients to offset some of the financial burden.
Okay.
If you can tell me who, I can make an introduction, because the guy in charge of that used to work for us.
Oh, wonderful.
And maybe that could be a way to provide assistance to some of our patients that could normally otherwise can't afford cancer
I'll be
treatment.
happy to share my cell phone number if you can get us in touch. I don't know if our social worker knows them, but
Okay. And then the other thing is, I'm also on the advisory board at UT Southwestern, Siemens Comprehensive Cancer Center. And is there anything there that I can help expedite? Because they're looking for screening for the underserved community and all that stuff. And as I sit on the board there, I don't see a lot of activity with JPS. I think
and this is something we
if they
did.
do more for Harris County, which is kind of strange, because it's way down south, and we are just across the 360 from them.
Yeah, and I didn't talk about this, but we've been in discussion with UT Southwestern about allowing us and partnering with them to give us access to clinical trial. That partnership finally was finalized, and now we are part of the ECOG Collaborative Trials Agreement. So through partnership with them, we will be able to offer clinical trials to our patients. The reason I didn't bring it up is we've been putting a break on it for now because of staffing issues at the cancer center. We don't want to start clinical trial when we don't have all the support we need. But yes, definitely there's more room, because for an NCI designated cancer center like UT Southwestern, they should be encompassing of Tarrant County.
Because we have an active program going on right now to help the minority underserved community to get screening, because you don't want them to be into the treatment room with chemo and all that stuff. So if there's something that I can help expedite or set up a special meeting, I'll be glad to make that introduction and maybe join the meeting to help.
That'd be
put people
wonderful.
together.
We
Just
can
let-
use all the support we can get.
Thank you.
That's it. Any other questions?
I have two. First question, and then my second question, Fran, Robert, or Derek. 1, 3. Can you go back to your first slide, the very first one? Yeah, no, go back. That.
Yeah.
On the spiritual care, does that entail family counseling also?
Yes, so we partner with our chaplains, and they provide support to the patients and their family. Our palliative care team has a spiritual counselor with them and social worker and chaplain with them. So they provide grievance support for the families. And that was one of our biggest one, is bringing palliative care. Traditionally, it used to be housed at the hospital. Now we have outpatient palliative care clinics at the cancer center, to where we're able to provide that support on both the inpatient and the outpatient side.
Okay, yeah, my concern is way before the grieving care, that cancer is a major shock to those families, and how we help those families matriculate through that process. That's what my concern is.
Yeah, sure. And
That's where our cancer navigators come into play, because they are that contact and they're assessing what's going on with the patients mentally and physically. And they're able to then provide some of that psychosocial support to the family as well as the caregivers and the patient. And then when it seems like it's beyond their need, that's when those resources go out to the community or to some of our other partners who can help provide that more in-depth need.
We do psychosocial screening for all our patients, meaning we don't just check their blood pressure, we also do psychosocial screening when they walk through the doors.
Good. Okay.
Your next question is to Trent. Go ahead.
I heard 3 names in there.
I hear that. Let's take a part.
I was there when they cut the ribbon and went in. Dorothy and I both.
Right.
And it's an awesome facility. But how does that play now with the bond program? Is that something that's there to be, or will it be matriculate through the bond process? Does that go away, or just?
I'm going to defer to Robert because it's not been something specific in the protocol.
We initially had the opportunity to get that building from a lease factor, but we also can grow into it. So at this point, we still, I mean, we're using a lot of space of it, but we are not to the point where we'd have to build a new facility. So that was part of, wasn't bond money, but it was part of the bond effort. It was part of that expansion program. So we're not at a point of saying on our bond program, you're going to have a new oncology center or cancer center. That one is able to, we can live within our means for now, for a couple of years, good number of years.
Yeah, remember we did the capital sort of adjustment when that building came available, and we looked at it closely, and everybody agreed, hey, let's take advantage of that and go get it. And actually probably took some of the pressure off of what would be ultimately the bond program,
Yes.
because that need was being met. This is really great. Thank you all for what you're doing. Just a couple of questions, especially Dr. Debose, as it related to preventative medicine protocols. And with COVID and with, not being able to see patients as we normally would, are we getting the kind of communication across departmental lines so that when we have connection patients or even just walk-in ED patients, are we able to put in place the preventative protocols that you all need to make sure that we're at least minimizing the chances of encountering those stage 4s much later, as opposed to maybe walking in ED with, with a bronchial infection?
Sure. What we're blessed to have at the cancer center is the cancer registry, which provides us with immense data about every single cancer patient's diagnosed within the network, whether they make it to the cancer center or not. Great. So we were able to share that information with our community health partner. So when we saw that we're seeing more stage 3, stage 4 breast cancer, we went to our primary care doctor, we went to our mammography partner and told them, this is the trend we're seeing. We need to focus on that area. Same for colon cancer. Right. We were able even to give them data based on zip code where these patients are to be able to help them target the screenings better.
Great.
The problem is playing catch up at this point with the missed opportunities from 2020.
Yeah, I really salute the programmatic aspects of what you guys are doing, to know that we have a group that is forward-thinking enough in nutritional services to pair up with the food bank and make sure those patients actually have groceries. I think, honestly, every board member would tell you that's our goal for all JPS. As we start looking at, particularly at the bond program and all the things that this bond program touches when it comes to preventative medicine, community health, and population health, the idea of even looking at locations relative to what we might need to be doing in the community for these services that we've not traditionally been a part of, but that are becoming increasingly important. You're pioneers in that thinking, and we really appreciate that. Great work.
Thank you. Our pleasure. And when we got asked to participate in any community event, they usually ask us, would you come and talk to us about lung cancer? And I usually say yes, and when I show up, I talk to them about smoking cessation. It's like, I don't want you to have lung cancer in the first place. That's the best way to treat lung cancer. So, thank you.
Good job. I have a quick question for you on the patient navigation. I'm assuming financial assistance and all that stuff is in that group. I know we're good at 340B program. How good are we? Are we prepared to help them with the patient assistance program, with the drug manufacturer and all that stuff?
Yeah, we have a very active pharmacy assistance program. They're screening all our patients all the time. So as a provider puts in the treatment plan, they're already automatically in that patient doing that reconciliation to see if that patient is eligible for support. Okay. So that way, once we know whether they're eligible or not, we can then make Plan B to decide how else to help that patient.
How good are you guys? Do you guys have a program in place to defend our position when it comes to appeal with insurance company? Because a lot of time, the plan design is one thing, but the people on IT loading the contracts is another thing. And they may say they pay, but the system will kick out until you go through the right formal appeal process for that type of.
Yeah, that's
Reimbursement.
becoming more and more of a challenge. So we have put in place a process within the Cancer Center to where if there's an appeal, it would come to the nurse responsible for that patient. And then if that appeal is still unresolved, then it goes back to the provider, and we make sure that the provider himself would call and defend their position for that protocol. It takes a lot of time, and it's time-consuming, but that's the best we could do for our patients.
Because a lot of time I've seen the mistake is being made is that they're trying to be an advocate for the health system. So you're trying to argue with the insurance to update the system to benefit the mass.
Yeah.
A lot of time it doesn't work that way. You go one by one, they'll pay for it, and it's a lot of time consuming, and you have to be able to defend the position because sometimes the admitting diagnosis is different than actually treating admission, treating diagnosis, and that drives, and all the policy behind that may drive away because, stage 1, stage 2, they may not cover for it, so you have to use different drug. But if it fails, then you can use it's stage 3 and 4. But if they're already stage 3, and the system won't pay, and that's where they will need the help to defend that position to get paid, because the difference can be $50, $60, $70 million a case.
Definitely. And all it takes is one wrong click on that computer system to where you generate the wrong information to the insurance company.
No, actually, more than that. You can do everything right, they still
And they
get
still do it. Yep.
Still do it.
Because their system is 2 years outdated, because they don't update their rules every year. So those are some of the things that we got to.
Yeah, but we have in place, we use what's called the national guidelines, and we have a treatment pathway, which is a computer software that says based on the most recent data, this would be the best treatment for this particular patients. So we have decision support that would show that the treatments we're giving are the appropriate ones. All it takes is some extra effort from us, and we're always happy to do it.
They'll wear us down before they write checks. I just want to make sure. Because
It's hard to wear us down.
for me, no money, no mission.
All right, any other questions? Well, thank you, great report.
Thank you.
Appreciate you
everything.
coming.
Thank you for your support.
Madam Chair, I would tell you that if we looked at, cancer is a focus, but if you look at diabetes, if you look at infant mortality, if you look at any of the long list of unfortunate comorbidities, there's a huge amount of departments that can do that. Our focus is not just on cancer, but we do an incredibly great job with cancer. And Dr. Sorley, who you met, she's been with us, she just celebrated 1-year anniversary. I rounded in oncology last month, and she knew every individual's name. That's the kind of employees that you want that get to know their staffs.
Well, I think what I'm finding out is working with Dr. Becker, that for diabetes, they're doing some great things too. So we need to bring more and more of that to the board.
We will do that.
Okay. Next, we have Dr. Hurt.
Thank you, Madam Chair. Excuse me. I appreciate this opportunity to give you guys an update on the medical staff. So just to reiterate our oversight functions, we met on Tuesday for our performance improvement and quality reports, where we reviewed and approved the PSI 90 for September. We were grateful that Laura Burnside, Senior Vice President, Chief Executive Officer, along with Alex Moore, Director of Patient and Clinician Experience, presented their fiscal year 21 year-end patient experience data and informed us of the vendor change to Press Ganey for fiscal year 22. Dr. Elliott, our Senior Vice President of Academic and Research Affairs, presented on graduate medical education, along with efforts to emphasize our diversity, equity, and inclusion by the creation of a diversity, equity, and inclusion subcommittee and requesting support from the MEC, which was granted. In addition, medical staff approved the following standing committee minutes: medical record, utilization review, ethics, and P&T, which is now medical staff committee. And in our consent agenda, we actually approved infection prevention and control plan and authority statement, as well as our fiscal year 22 QAPI plan that was recommended by the Patient Safety Quality Governance Council. Our delineation and privilege project reboot is ongoing, with more departments being reviewed. Individual chairs are working with the medical staff office and our hardware consultants to revise current forms for both best and current practices where they merge. We are hopeful that we will be completing this project at the end of the calendar year. And once completed, the delineation privilege project will go through their standard process of approval by credentialing committee, then MEC, and we will bring them forward to the board at that point. We chose not to have a retreat in October because we were so busy with so many other projects. So we deferred our education, and Dr. Miles, as president-elect, will take that on come the next quarter, after the first of the year. And further updates on the bylaws, our work group for the subcommittee is deep into Article 4 of our rules and regs and working towards all 7 articles. Upon completion of those revisions, tentatively also by the end of the calendar year, we'll move forward these to the MEC, and then after that, of course, to the Board of Managers for approval. And that concludes my report. But I did want to say I was really clapping, not just for Dr. Gabosh and Dr. Soy, but also for the fact that he started his lung cancer talk with smoking cessation. So, thank you.
All right. Are there any questions for Dr. Hurt? Okay, all right. Dr. Becker notified me he'd be running late, so what we're going to do is, he's taking a test today, so we can just skip him. Maybe I'll just defer him to do his report next month.
Yes,
Okay?
ma'am.
All right. And then, so next we will have the committee reports. First up is Steve and then Trent.
Yes, ma'am. Thank you, Madam Chairwoman. We had a Finance and Planning Committee on the 23rd of September where we reviewed the August financials and forwarding them on for the board's consideration, as well as several new contracts that we hope that you will approve.
Okay, all right, thank you. You have a question?
Yeah, I was thinking that since that's a finance report and that deals with numbers, that Steve was going to get the score, give us the score before he finished.
Oh, no.
All right, I'm going to move right along. Trent.
Before it disintegrates any worse. Thank you, Madam Chair. Planning, as you know, has been joined with finance for the foreseeable future so that we can make sure that we have no delays in recommendations relative to bond programs through finance and can go straight to the board. We're continuing to observe that process. I will briefly introduce Derek when we start the planning update in a minute, so I'll defer the rest of my comments to that.
Okay, all right. So next I have, so the bond update, you're going to bring that back later, right?
Yeah.
Okay. All right.
When we start the facility plan.
Okay. All right. Okay. So then I will do the HR Resource Committee. We met on September the 23rd, and the committee unanimously voted to retain an outside compensation consultant to conduct an executive compensation packet, market study, in order to present information to the committee that will allow us to evaluate and make recommendation to the JPS executive team members' compensation, including salaries and overall benefits. We have directed staff to present to the committee with 3 potential consultants that we can select. The board will be doing this. This is a board committee. We intend to make the consultant selection at the November meeting, and we'll come back to the board once the work is concluded. Are there any questions? Okay. All right. Next on our list is the consider approval of the 5th modification lease agreement between Andrew and Dylan, and that's Zelia. Oh, you're going to do it, Sharon?
Sharon's going to do it.
Sharon, okay.
Good afternoon. I'm sitting in for Zelia today. This is a renewal of a lease. This is for the Central Arlington Behavioral Health location. This is a 2-year lease at a cost of approximately $187,000 annually. And it was budgeted for. Thank you.
Are there any questions for Cheryl? Okay, then I'll entertain a motion for approval.
Move approval.
Okay,
Thank you.
moved by Steve and second by Zim. All those in favor signify by saying aye.
Aye.
And those opposed by nay. Motion carries, unanimous. Okay, next we have Dr. Elliott. And Dr. Elliott, what I would like to do is you have a couple that you're going to archive.
Yes,
And so
yes, ma'am.
we can do this as a group project. That's what we can do, if that's okay with you.
Sounds great.
Because unless there is a question on one of the policies, did anybody have any question or concerns on it? Okay. Then, okay, I will move for a motion to approve the policies and to archive the other two. I guess, do I need to do them, the archive separate, or do I just need?
So, yeah, we'll just say we're requesting permission to archive policies AA 1100 and AA 1300. And then we are bringing back, just in the ordinary course for their triennial review, the other policies that are listed at items 3 through 9.
Okay, all right. Somebody got all that, right?
I move as identified by general counsel.
Okay.
Second is approved by general.
All right, okay. It's moved by Steve, second by Ralph. Are there any questions? Okay, then no questions. All those approve the recommendation signify by saying aye. Aye. And those opposed by nay. Motion passes. Okay.
Thank you so much.
All right.
You did an excellent job, Dr. Elliott. Excellent. You owe Daphne lunch.
All right, now we are for the review of the master facility plan. Trent, that's where you come back. Okay.
Robert, do you want to introduce anything before my comments on that?
What I would like to do, first of all, I'd like to tell you, Reverend Emerson, that we've had 284 of our physicians vaccinated, and that's out of, we have probably 600 that are credentialed here, but not all that are credentialed here are here, and Dr. Hurd can speak to that, but 284, I don't know the percentages, but that's a pretty good percentage of the amount of physicians that are active in the organization.
Yes, we do have a large number of physicians who are credentialed and has seen little to no patient volume at all for some reason. They
Right.
like to stay on
Yeah.
our medical staff, but additionally, we do have some who are specialists who very rarely we need them, but we do every once in a while, like a pediatric cardiologist for a NICU patient or something. So they have very limited amount of patient interaction here, but they are still with us to be available for us to do that. So some of those, they may be vaccinated, but we wouldn't have their records. 'Cause
Yeah,
they're
and
probably
that's going to be
vaccinated at their main place.
that's going to be the point there, Reverend, is if they're here on a limited basis, in all likelihood, they've probably been vaccinated at Baylor or they've been vaccinated at THR. But to have 284 out of our basic 600, that's a pretty good percentage, because of those 284, those are the active ones that are seeing patients on a daily basis. And to Dr. Hurd's comment, we wouldn't know if they've been vaccinated outside of here. So thank you for that question. To Mr. Petty's point, I think the action that the board took by establishing an executive committee to deal with bond issues has been probably the most effective thing we've done, in the sense that it gives us a dialogue to talk, gives us the ability for discussion, where we're going, what we're doing, and that's been helpful. But then that gives Mr. Petty the ability to come back to you all as a board, and action does not take place there. Action takes place here, and I think that that's what really this is about. This is about giving you all updates. Trent gave a really nice update to the Commissioner's Court a couple of weeks ago, and we've now made some more progress amongst staff and amongst Trent and the others, and we thought it was probably time to come to you all and give you an idea of what's going on so you can be as topical as possible. So I'd asked Mr. Petty if he would be willing to do a version of his introduction that he gave to the Commissioner's Court, and then we're going to let the team at Broadus come up and talk to you. And the broadest team is going to be segmented in really three. Derek's going to come up and tell you the broadest side of things. Lindsley is going to come up and talk about the guidehouse and the data. And then we're going to have case strategies talk about our communications with the public and what we're doing with our efforts to enhance the MWVE efforts to create an expansion of those that participate in things that are happening at JPS. So Trent, if you don't mind.
Thank you, Robert. And first of all, just thank you to Roger and Steve and Dorothy and DT for being a part of this process. We spend 3 or 4 hours together on Fridays, and we put a lot of work into this.
Your calculation is not correct. I don't think it's 3 or 4 hours. I was going to say
4 or 5 hours, yeah. But I'll tell you, it has been beneficial because it's allowed us to kind of hear and in draft form some of the ideas and thoughts that are really going to be put into formal form for you and ultimately for the Commissioners Court. And Robert's right, I did get a chance to kind of go over our process with Commissioners Court. Obviously, they're very interested, not just in the process, but in the execution of that process when it comes to awarding bids, when it comes to reviewing RFPs and RFQs. And I think we have provided a mechanism now where there seems to be general comfort that this process is transparent, it is data-driven, and it's really focused on trying to put the most important things first on the agenda. I'll tell you that we have invited and they have accepted our invitation to be a part of this committee. Mr. Manius has been at the last 2 meetings. So he has been the one that the court has sort of identified as being he's going to be the sort of the mouthpiece, if you will, for the Commissioners Court in that process. But they're very much involved in it. They ask questions. They are just like us. I mean, they're one of our team when it comes to making sure this information is being disseminated. So what you're going to hear today is frankly, I think probably the most important report that we have had thus far. And it's the culmination of years of work to try to begin addressing what this board has been really trying to get to for a very long time in terms of not just, how we're going to fund it, the mechanisms of order, the priorities, but what's this place potentially going to look like. And we have allowed staff to really take the lead in this process and have expected them to be data-driven. We've expected them to take board policy criteria and apply that to planning that they believe makes the most sense for JPS. And I think there is literally some genius work in this. I mean, this was so impressive when we saw it at the committee the other day, and I was thrilled to be able to say, hey, it's time and we can bring this forward. And Broadus has done a great job. I want to call out Adam Lane. Adam has his own genius about this, and his ability to wander through the maze of facility needs here is sometimes amazing. But that entire team is doing a fantastic job. And there's always going to be criticisms that it's not going fast enough. Why haven't we put shovels in the ground? What's going to be the location for the first clinic? I mean, we continue to feel those questions. They're all being answered in time. There is a process. There's a system by which that's going to come forward. But we wanted to make sure today that you had the benefit of hearing and giving input, questions on this overall facility plan, what it looks like, what was the data that went into it, how does it compare with the original blue ribbon suggestions, what's changed since then. So this is an important report, and on behalf of the committee, we're happy to answer any questions of the board, provide any additional input you would like us to provide, but this is your time now to really hear this, digest it, and make sure that as it leaves this board and goes to Commissioners Court, it has our hopefully universal and unanimous stamp of approval. So, Robert, with that, you want to call up the order of the folks?
Yeah, Derek, why don't you come on, and then I'll let Derek go ahead and introduce, when it's their time to come up, the members of his team. But as you all know, Derek is a part of the Broadus Levis team. And Derek comes to us with a bit of insight talent because at one point in his career, Derek was part of JPS. So after he left JPS and went on to other aspects of his career. He also still volunteers at JPS. So he knows the hallways well, and he knows where buildings should be, and he knows what our patients are needing. Yeah, he is.
I don't think I heard that.
He is. It's a good program. I wanted to announce that there is no money transferred between us and Brighton. No. Now, you notice that Derek got real concerned at that point. No, he volunteers time outside of his broadest time. But with Derek's past being part here, Derek's volunteer efforts here at JPS, I think he does have a really nice insight. And then I think the team he's assembled is really starting to understand JPS, because the one thing I've always told Derek and others, if you've seen one public hospital, you have seen one public hospital. You cannot say JPS and Parkland, they're real similar, or that, because we're all different, although we're under the guides of a public hospital. We all have the same statute to operate, but we all operate differently. So, Derek, if you don't mind, why don't you go through this? And I want you to know, and this is for Tricia Elliott, if she's listening, they went through the same scrutiny on slides as well, okay? So we did have a large amount of slides, and I don't want that to be part of my evaluation, but I spared you all 72 slides. We've reduced it down a little bit. So, Derek, go ahead.
Thank you, Madam Chair. Thank you, Robert and Trent. It is an honor to have this opportunity, and I was volunteering downstairs today, and I can tell you this won't move fast enough. It just won't. But we're doing the best that we can, and as soon as possible, we're going to have new facilities for your patients and for your staff. It is very exciting. So I would, by way of introducing a couple of people that are getting ready to come up, I'm going to do the master plan, do an update, and then I'm going to have DeLon Green come up and share with you about the MWVBE plan. He'll go last. And then Lindsley Whiffy with Guidehouse will be talking about the ambulatory network plan. So with that, it's important to note that the way that this is set up, we have a couple of planning efforts that are happening simultaneously. So we have the ambulatory network, which is everything outside of the main campus. There's a lot of things that do factor into that, into the medical homes and other opportunities that are out in the community, but that's what we're calling our facility network master plan. And then we have our campus master plan that is focused here at the main campus. And so here in just a few minutes, Lindsley is going to focus on the facility, medical home, and the ambulatory network strategy. So this just gives you a little glimpse in a dashboard format. We have several dashboards that we're using to track our progress and the work that we're doing. This is one of them that gives you an idea of where we are in this master planning effort. We have several team members besides Case Strategies, Guidehouse, our team. We've got Price Waterhouse working with Sharon, and several others that are contributing to the overall planning effort that we're going through right now. And this represents some of that effort, and we keep track of this in a dashboard format. We also have some RFPs and RFQs that we've talked about. Those are all in a dashboard format, so it helps us stay on track and where we are going through the process. There was a very exhaustive report and work that was done that was your enterprise-wide risk management program that was led by your facilities teams, outside engineers that came in and really looked at and assessed the existing infrastructure and conditions here at the main campus, as well as the ambulatory clinics out in the community. A lot of work went into that. We were able, it was really good forethought on JPS's part to have that work done. We are utilizing that report, very exhaustive, has got a lot of work into it that helps us shape and understand what the existing conditions are here at the main campus. So we just wanted to highlight that work has been completed, and we are utilizing that work and the database and everything that was put into that work. So for the master plan, the overall campus, we look at a lot of things, and Robert is right. We went from about a 70-plus slides down to a few, maybe a few more than 5 or 6, but there's a lot more information. But what we do is we look at the overall campus, and we look at what the existing conditions are. What are some of those things that are things that will not move, we don't need them to move, and then what are things like transportation, where are the bus stops, the current bus stops, all of those things we look at to see what the existing flow is for vehicular traffic, pedestrian traffic, and we take all that into consideration. We also look at where's the available areas to build, where are the available areas that we want to be able to leave open for the future. So this plan is not just a plan that's going to take you for the next 10 years, but for the next 50 years. And so those are the things that we look at when we look at an overall plan. Here at the end is kind of the highlight at the end. I'll show you the circulation and some of those patterns and how this plan really has shaped up and turned out to be a very, very effective plan. So phase 1, we're looking at what we're calling our enabling projects. So there's several projects that we need to do in order to set up for the major projects that are coming down the road. This will be some things that are really critical, like I said, so that it doesn't interrupt your existing operations. That's something that will be a challenge here no matter what we do, but we want to make sure that we have plenty of parking, that we have plenty of access so that patients and staff are not majorly interrupted through the process. So at the north, we've got, actually first, the Hemp Hill parking is when the Hemp Hill building comes down, that'll provide some parking over there that we'll need, and I'll tell you why here in just one second. And then we've got a fairly large parking garage that's going to go up to the north of the near Magnolia Street, and they'll provide around 2,600 cars. We're using DeShazo as one of our team members that's doing the traffic and studies and all the parking studies, and helps us determine where locations need to be for that parking and how large it needs to be. The blue area, that's where the old St. Joe's site is, we need that for some temporary parking because we're going to displace parking. So we want to make sure that your staff and patients still have a convenient place to park. So we need that up front so that we have that space available so that when we displace parking, we have enough parking that's there. So that'll be a temporary lot, and that's something we're going to work with the city of Fort Worth on. When we say temporary, it's going to be there for a short period of time, relatively short period of time, and we don't want to have to build it to and waste money. So we want to make sure it's good. Temporary parking, so that's in the middle. There is a central utility plant, it's kind of light blue, that's on the right. That's really very, very important that it is central, and in this plan it is in a central location. That will house all of the new mechanical, electrical, plumbing, and the infrastructure that's necessary to build out the campus. So right now you've got separate central utility plants. This is going to put it all in one location, much more efficient. It'll be a cogen plant and be right where it needs to be. A project that's a little small sliver just to the north of the pavilion, that is a very, very critical project because that's really the connector for the new hospital that's going to go up to the north of the pavilion. Currently, because we have an ambulance entrance, we have a loading dock, that is in the way. So we need to be able to have a way that we can provide a connection to the pavilion so that we have good flow for patients and staff and for all the equipment. So that's going to be a really important project. To the right of that, we have the pavilion parking garage. We're going to add 2 floors. It's when it was originally designed, allows 290 cars. So we're going to add parking there. And then really one of the most important projects. Yep. Okay, very good. Thanks, Trent. So this is the central utility plant that I was referring to. Temporary parking garage, temporary parking, surface parking. This is the parking garage. And then to the north of that is the medical office building. This is a great opportunity for us to build medical office building and ambulatory surgery in this building. And the benefit, one of the benefits of that is offloading the OPC, the current OPC, to bring all of our specialties up here into that medical office building and help offload the JPOC buildings, the 1350 and 1400 buildings. And so we bring all of our specialties into one location. That's really very, very important, because right now, as you know, when patients come in, they have to go in a lot of different places, and if you've spent time on the second floor, you know what I'm talking about. It's very, very important. So that's another very critical, important project, is the medical office building up along Magnolia Street.
Dorothy?
Yes.
Derek, I don't mean any harm. I don't see your pointer.
Right.
I think that's Robert's point, but we need to get one that actually you can see.
Well, I'm sorry.
This, correct.
I thought it was just me. I didn't say anything. I thought, I can't see any color.
I apologize.
But, okay, we'll get you a pointer that points, because that is mine. That is my individual pointer. We'll get
Okay.
you- Or maybe Broadus can do it. If you don't charge us, maybe Broadus will get you one.
And we're volunteering anyway, so might as well donate a pointer.
Why not?
Yes.
On Magnolia,
Yes.
is fronting Magnolia the office building or the parking?
That is the medical office building would be fronting Magnolia.
Oh, I see it then.
Beneath that or south of that will be the parking.
Correct. And this lower section right here, next to the JPOC buildings, this is the parking structure here.
Does having that parking there, I wasn't at the last meeting, sorry. Does having that parking there, does it kind of inhibit flow from the rest of the campus to that building? I mean,
No, we will have multiple access points to that building. So there will be access from vehicular really from three sides. So we're going to provide that off of Magnolia, we'll provide it off of Main, and we'll provide it off of St. Louis to get into the parking. And then we will also, our plan is to have this as an open first floor, so you can go through that building. If you go down Rosedale, there's a couple of buildings like that down Rosedale where you go through, it feels like you're going almost through the building in a way to get to that parking.
We had an extensive discussion at the last meeting about that. Long discussion. When you weren't out, we had a long discussion about that.
Right. So this connector that I was referring to here is north of the pavilion. This will allow the connector to the new tower, but the other thing that's really important about this is that it's going to have the opportunity for us to help the emergency department for some expansion capability, as well as the ORs on the second floor. So it's really important, very important project here. Lastly, I want to talk about the PEC. So in the lower left corner next to the Trinity Springs Pavilion. Perfect.
Thank you. One more thing I can do. Add to my list of 2 other things I can do. 3.
So the PEC is, we're calling this the PEC 2.0. And the reason for that, this will not be the permanent home of the PEC. There is a desperate need, as we know, for relief, the existing PEC. What this will enable us to do is to allow us to have the behavioral health and the PEC in its permanent location, but it'll give us the ability to do this up front. So as soon as possible, we would like to start on this building. It will be a permanent building, very well-built building, but it'll be the temporary location, and we'll repurpose this building once we get the behavioral health tower finished and the PEC.
That's one thing I think that it's important for everybody to follow in this pattern, where we're going to be building new buildings that we transition, where we know those buildings are going to cost us $700 a foot because they have to be equipped with all the things necessary. We're not going to be using those buildings for administration, right? We're going to be using administrative buildings for administration. Hospital-related buildings, services are where we're going to be spending the money that allow us to transition seamlessly without having to go out there and spend a gigantic amount of money now on buildings that are not going to be in future equipped or necessary for hospital use. So that's one of the things that you see constant throughout this whole process. And they've really done a great job of making certain that we're not throwing money away on projects.
We've also been very consistent, for those of you who have been on the board, and we've had other consultants come in here, tell you that this main campus facility was not built, particularly when they built the new pavilion, with the patient in mind. We lose a lot of money, time, and talent transporting patients in a very awkward way through this system. So with this and this plan, two things. One, the takeaway is, because you all as board members will catch this from community folks saying, really, you're pulling down money to move a parking garage? You're doing that. There is, in any project of this magnitude, an amount of money and effort that needs to take place so you don't recreate the mistakes that the organization made 30 and 40 years ago by putting buildings up and just adding and not thinking about patient flow. So you have to do that, so that our hope is that all your acute care is on one side, and you're moving folks from floor to floor, not across a skywalk to another part. And that's where JPS made its mistakes, and that is, we just looked at the land we owned and said, let's put the pavilion there. We didn't think about, or they didn't think at that time, what it was like to use nurses off the floor to transport folks, because you're down 5 transporters. And that's oftentimes what nurses do here. So you're going to see not only efficiency, you're going to see, if you take the time and the effort to create the proper infrastructure, this community will applaud this board in 30 years, because you all will have made the right decisions, in my opinion, on the main campus, in addition to what we're going to do in the community.
Wellness program.
The what?
Wellness program, by making people walk more.
Well, we want them to walk more, but we don't want them to walk more with a patient in front of them.
Dr. Hurd, you had a question?
Yes, you had mentioned that PEC, and I guess I'm kind of ignorant of this. You mentioned the PEC temporary in the red square, and then the behavioral health and PEC altogether. Where will that building be?
Yeah, thank you.
Okay.
Yeah, this is, we've got 4 phases. I'm going to work through these really quick to get to that. So this is phase 2. In this particular phase, we've got a couple of buildings. They're support buildings, but it's really important to note that when we've gone through the thought of this, it's also about constructability, and it's something that contractors love to talk about, but it is very important, as the laydown yard. Where are materials going to be, and how close can we get those to the site? So once we've got our parking garage completed, this will become a laydown yard to prep for a couple of very important buildings, which is a couple of support buildings that are important, but we need that space to get these 2 buildings. These buildings will go up quickly, but we need that space, so that's why we have those in phase 2. Then in phase 3, this is when the hospital goes up. And so what you see in the red area is exactly what Robert was just referring to, how we're keeping the acute care zone in this area. So we have the pavilion, we have new hospital. What we're at least looking at right now is a new D&T, diagnostic and treatment block chassis, and then potentially 2 patient towers, and that's patient tower 1 and 2. And so this is where the new hospital. It's great because you have a new front drive-up entrance right off of Main Street, and we've got our central utility plant. We have our connection to the pavilion. We have close parking, and so this is where we've got. And we're basing this right now on the Blue Ribbon report of number of beds, but this is still the work that Guidehouse is doing currently to determine exactly number of beds that we need in the care model. So that's what we're basing this on right now. So this would be the new tower going up in phase 3. Then phase 4, we've got the hospital complete, and so now what we want to be able to do is utilize something that's the adjacencies that are critical to all of the buildings, but especially to behavioral health, and that's having it connected to the emergency department through the Sky Bridge. Here, we've looked at other options that are very limiting. There's unique attributes to the behavioral health PEC. They need access, at least 3 points of access for ambulance, for walk-up, and for police. So having the flexibility in this location, putting it next to the pavilion through the connecting bridge provides the permanent location for behavioral health and for the PEC. And at that point, we can repurpose our PEC to future use. Correct. Yes, sir. Yes, they will. I will bring up next, here in just a second, the circulation. And it shows where those existing drop-offs are. Yes, sir. There's one here. There's another one up here. But we'll show where those are.
Right. Transportation.
Can you remind me, how many floors are we talking on the towers?
We're talking about 7 floors. 7 floors. And the thing that's important that we're looking at closely with your team is, the nursing, the patient ratios, and making sure that, we're not having these potential units that have, 36 bed units where you have the long corridors and a long way for staff to get to supplies. So the thing that's really important to note in patient tower, especially when you need close to 600 beds, is every room obviously has to have access to the exterior. So that's the reason why we're looking at 2 towers versus 1 big tower, because we end up with a very, very large core central area. Which is important, but what's really important is those the patient rooms having exterior windows. So that's one of the reasons why we're looking at it this way. The other opportunity potentially can be that we could build patient tower 1, get it finished, get some beds open, and then finish and maybe in 2 phases. So that's another benefit of doing it that way. So this is the last slide here, but this illustrates the circulation, your existing circulation, and then I'm going to flip quickly over to how we're able to do drastic improvements on circulation. And so what you see it's a busy slide, I understand, but the thing that I would like to highlight is look at, if you can think of this in a 2D fashion, because your circulation, your pedestrian circulation in this yellow, that's all pedestrian circulation, and all of the staff and support is on the back side of that, on the other side, close to where our warehouse is and our loading dock. And so that's really important. A lot of people call that, on-stage, off-stage model, Disney model. Those are things that are used in healthcare now, so we don't have a lot of cross-circulation coming into the campus, as well as, from a vehicular standpoint, as well as the pedestrian and services. We want to keep those separate. So that's what this circulation pattern, again, think of it more in a 2D, not just a 1D, and a lot of that can happen up on the upper floors. So this is the end of the master plan presentation. Any other thoughts, questions?
What we'd like to probably do is get a hard copy of this for each member of the board.
Sure.
This was literally being worked on yesterday as late as 2 o'clock, so it wasn't ready to pass out. Yeah, Robert, if we could just make sure there's hard copies available for everybody, I think that would be good. And then I guess we can put this on the portal too, can't we?
Yeah, we can definitely do that. We can get you hard copies, put it on the portal, and Trent has this on his barbecue apron. So we can also have this in a barbecue apron for you as well.
Yes, Ralph, yeah, question.
Is excellent. Because when we were first receiving presentations and we talked about parking garages, I mean, I've once sat here and raised issue mentally. You know, why are we putting the parking garages in no buildings? You know, but when you see the presentation, you can better visualize where we're going with this. And so this helps, though, for when I'm talking to individuals, because just 2 days ago, a group at the church is raising the question, when? And now I have something I can share and explain to them why we're doing the process the way we're doing it. So this is excellent.
Thank you. I'm going to introduce Lindsley Whiffy with Guidehouse, and she's going to take you through the ambulatory network in the medical homes.
Add on to what Reverend Emerson's saying, you know, we're doing all this while we're still caring for patients.
Yeah.
Like, we're flying the airplane as we're redesigning it.
Yeah, exactly.
And I think the other thing is, the TSP is still there, and if we need some expansion, that's already thought about how we could expand. So I think it's a great look at the future.
Did ask that this be sent out, our copy be sent out to the board, which I agree. I do want to caution that this is not fixed in stone. This is how we see it today, but as we start to do these build-outs, as we look at how we're financing, this could begin to change as to how it looks, but we do see this as a great plan. So I know Reverend Emerson will come back to me and say, but you said you were going to put that building on that corner. And so I want it on the record.
I just want to make sure we have a parking garage where you have to like go against traffic and make a U-turn and all that. Yeah, that's a lot of fun. Yeah.
We're going to name each of the buildings out of each one of these.
We've got a separate garage just for all his cars. That's good.
We do have an opportunity for everyone to participate in the new foundation drive relative to these costs.
Bingo.
So hold on to those thoughts, because it's very important.
Amazing how that works, isn't it?
All right, good afternoon. Thank you all, board members, Madam Chair. So we have done a lot of great work in conjunction with the Broadus team, looking, as Derek is talking about, the work we're doing in parallel. So while we're looking at the opportunities for what's going to be the volume projections and the bed need on the main campus, we are also in parallel looking at what are the opportunities for potentially decanting some of the existing volume and procedures and different, what is existing on the main campus, what could we potentially push that out into the network, and creating greater access strategies for the JPS patient population. So we've been working very closely in collaboration with the strategy team, the network team, and all the leadership at JPS, and have been able to really get a better understanding of the needs of the community based on data. So what we're going to be reviewing with you is really data-driven and will help us understand where are those priority points across Tarrant County in which we can look at developing our options for medical homes in the future. So what we've gone through to date is a two-phase process and looking at market prioritization. So we've looked at the Blue Ribbon Committee report and have done a refresh of that data analysis. So if you remember, that document that had developed prioritization opportunities throughout the network, we looked at refreshing that information with current data. And the elements in which we were evaluating the network to see where there might be opportunities are based on these factors: population size, the 5-year population growth, and primary care need. Within the Blue Ribbon Committee report, we specifically were focused on the number of families under the 250% federal poverty level, the percent of families within that same range, and then the ED market share. So what we did throughout this process is looked at that data and refreshed it with current data. In addition to that, in alignment with the strategies that JPS has developed and done a lot of work in their strategic plan, thought about what else in addition to those factors are going to be really important for JPS to ensure growth for the future. So through that process and working very closely with the strategy department and developing, making sure that we are really working in collaboration with what some of those future strategies within JPS would be, felt very important that we needed to also think about life expectancy and socioeconomic needs based on the CHNA that was developed when we're thinking about a community's prioritization. So running community needs prioritization analysis in parallel with also thinking about where might there be additional opportunities for growth for JPS, and that being the commercial and Medicare lives market. So in addition to the population growth and the primary care needs, thinking about the percent of commercial lives, percent of the commercial payer patient capture ability, which means of those commercial lives that reside within Tarrant County, which ones would we reasonably be able to target? And that's really based on past experience, and of those patients that have commercial insurance have been seeking JPS in the past. And then also targeting how could the reasonable Medicare lives as a percent of total lives at JPS. So folding into that past analysis, really wanted to take into account these additional factors.
Could you educate us a little bit about how you refresh the data, because, and what kind of data, how old is the data, because of the explosion of population moving to Texas, right? And with the inflation that's sky high.
Yes.
And it push a lot more people into poverty. So I just want to make sure that we get some education on that one, because I have no idea where you guys pull the data from.
Yes, so we've got, as Mr. Earlier alluded to, about 100 slides that support this, so we were condensing this, but we are looking at, really appreciate the question, because we have a very thorough analysis starting pretty high up at looking at Tarrant County, not only as just looking at Tarrant County, but all the surrounding growth. Starting really nationally, then zoning in on what's happening in Texas, what's happening in the surrounding counties, and what's happening in Tarrant County. And so we are drilling in, really, it's important to understand what those growth expectations are, and Tarrant County being one of the fastest growing populations in the country right now. But also, obviously, one of the fastest growing areas in Texas. And so all those factors are included, and we run that. We've got demographic data that we run through multiple different softwares that we have, but we utilize Truven to look at what is that population growth projections, and then we zero that down, and we're going to go from the zip code level, even looking at the block group level, as we begin to identify where there are opportunities for growth. But we have a lot of data that we can certainly, that are supporting our recommendations that have gone into this.
Other data besides Truven that we can cross-reference to see if they, because everybody, right now they just estimate, but nobody knows the validity of it.
Yeah.
But if you can cross over multiple data, maybe some variance there can give us some guidance, because going with one may not be enough in this unprecedented time.
Yeah, we actually have multiple, we've got we always are cross-referencing multiple data sources as we are going through this process, and usually triangulating as we have recommendations on different avenues of where there's opportunity for growth. I assume so. I'm happy to, we've got a report that we would be happy to share.
Get any response back, so it's almost like a black box.
Yeah, I'm happy
it's a key thing, because this one would derive everything else below it, and if we don't buy in on the assumption, then everything else will have questions later on. And I'm trying to avoid all that stuff, but I just don't get a good feel of the data. I expressed that the last time, and I will continue to express that, because I just don't see any numbers.
Yeah, I'm happy to share the report that we have.
Do you know when?
I want to be clear, the question is, you want to get some data, I'm just trying to make sure I understand.
Right, the supporting data, where
Supporting
we're
data.
assuming this, because if we're going to refresh the blue ribbon, what cross-reference are we using them? And is it at the time when do we go beyond proven to see if we can have another angle to see if two data set give us the same directional, right?
All right.
Because nobody knows what the future will look like. But I know for the fact that inflation is going sky high, it's going to get worse, and it's going to push that number a lot higher from into poverty and all that stuff. And
DD, you and I sometimes come from different, are you referring to like the life expectancy, those projected numbers, or are you talking about the economic growth?
The financial side of it.
Yeah, the economic growth, because in my world, I'm a Fed member, so we can pull down from the Federal Reserve and the OCC and the government, and I mean, I imagine that's where you get a lot of your
We've got,
database.
yes, and this is actually a compilation of, this is multiple
Yeah.
data sources in which we're cross-referencing.
I see where you're going, DT. I mean, there's multiple sources. Like I said, we have to pull down, for the banks, we got to pull down all the economic stuff. We got the feds, OC. I thought you were referring more to the life expectancy. Where's that stuff coming from? I got you.
But the other one.
You want the
is
true
driving
growth
everything
factors.
else, right?
I got you.
Because we don't know if we stay, as we move toward more population health, how much of that commercial business are we going to be looking at and all that stuff? 'Cause
And what's the income, projected generation?
Your question, DT, is bigger than that. And let me tell you why I think it's important, is you all later on are going to see, don't want to preempt your slides, but you're going to see zip codes that are being looked at from a growth standpoint. Not only do we need to make estimations on where the economic growth or lack of economic growth is, we need to make really strong projections on where to locate that, because I'm not going to be a great soothsayer here, but everybody's going to be happy when they see 10 zip codes. Where they're not going to be happy is when we build the first one, because everybody's going to say, my area is much more important.
Right.
So the area right around Grapevine is much more important than the area around Crowley, and Crowley's much more important than the area around Las Vegas Trail, and certainly it should be in Arlington. So we've got to stand strong behind those numbers so that we can honestly tell people, you as a board and me as administration and the rest of our team, that was picked not on who called us the most. It was not picked on who was frustrated with us the most. It was picked on where our patients need to go, and there's elements to that. So the economics of it and where your model wants to go, which I agree with, is where is our potential commercial payer? Where is the business model of JPS changing? And how can we predict that? You need that information, and you need to stand behind it, so yes.
It's scary when I walk into a Walmart or a Amazon, you see people being replaced with machines.
Mm-hmm.
You can't register with people anymore, and those people will be using, you're not generating any tax, you're not generating any healthcare, they're gonna, insurance. Those people will be JPS connection or Medicaid, because the people, the hourly employee will be replaced by robots or technology, and that's what scared me, is that number correct? Are we trying to solve? So
I think what we can do is, and we'll put this on the committee agenda, is we will put together a graphic, DT. We'll put together a graphic that will show you of the different variables that we're measuring, the specific data sources we use for each of those variables. And that will at least give you a picture of the cross-referencing of the data, and then we can support that with the actual data tied to that graphic. So there's a big global picture that says, here are the sources, and then here's the specific data tied to those sources. We can put that together for you.
Yeah, and I have that, so that's no problem.
I have a quick question. Why was 250 FPL chosen?
That is what is utilized for JPS connection.
For connections?
Uh-huh.
Okay. Most of just food for thought on this with the 250, because for a family of 4 at 250 is 66,000. For a one-person family is 32,000 a year. Healthcare.gov goes up to 400, and most social services go up to 400. So we might want to look at what that utilization, especially if you're going to go to 400, you're going to get more of that Medicaid, Medicare range as well.
So just as a refresh, this was the results of the original Blue Ribbon Committee report and where the areas of focus ultimately resided. And as you can see by the red stars indicated on the map are the areas that were recommended at that time of the issuance of this report. And then what we did is looking at all of those factors in the red map, you can see what the outcome of the refreshed Blue Ribbon Committee report data was. And so the dark areas that are darker and that the map on the left are areas in which there was a greater need with the Blue Ribbon Committee report updated findings. On the right, you can see the updated methodology in which we looked at that area of community need in conjunction with the commercial lives and Medicare lives combination of that analysis. And the areas that are in the dark areas were the areas of greatest need through that methodology. When looking at the maps side by side, you can see that there's a lot of parallel and similarities in the areas that have the greatest need. And when we looked at the top 10 zip codes between the two methodologies, they were the same. So between the two different methodologies, you can see from the refreshed Blue Ribbon Committee report, those yellow dots indicate the top 10 areas in which surfaced. And then looking at that updated methodology, those are the top 10 zip codes that surface. So a lot of consistency in the way in which the greatest areas of need surfaced. So this is in ascending order, no order of prioritization, but those top 10 zip codes based on those factors that have surfaced.
Did you hear what Lindsley just said? Those are not in order. So whenever it gets out into the community and somebody's going to say, those are in order, why did you go with that one first? They are not in order. They're just up there.
Okay, so these are the order?
These are not in order. And so these are the top zip codes in which we do want to are doing further analysis. And further analysis meaning what we're going to be looking at now are where the JPS existing facility locations reside, drive time to JPS locations, public transportation availability. So very important that we're looking at where are their current public transportation stops based on the population and cars per household. So if there are no public transportation available, is there a high ability for cars per household to be able to access the services? We're also looking at cannibalization, meaning if we were to put a location in a certain area, does that decant current volume from an existing JPS location? Or is there an opportunity to potentially expand services at a current location or even potentially consolidation of a current location?
May I ask you for one thing?
Yeah.
Is there a way we can add another dot in there and look at the impact of gentrification?
Oh, yes. Yeah,
because
sure.
I think we need to look at that to see if we're going to push the pool further away, then the location may not be appropriate in a few years as well. It might not change at all, but I just want to make sure that we have a view of that, just to make sure that we're not off the mark here.
Absolutely.
See.
I want to caution everybody. I was in charge of redistricting the last time that we did the census. And there was modest growth at that period of time. There's been tremendous growth since then, particularly in the last 3 or 4 years. But I don't know what models you have or whatever you're going to have that's going to do an accurate job of predicting where this population is going to go. We were talking about this earlier this morning. You've got a dynamic that's taking place at the south border that is going to affect this area, I think, more impactfully than we believe right now. We also have an area that does not like to spend money on mass transportation. We are so far behind Dallas and Dallas County in mass transportation. And the only reason that we've got a rail system between downtown and the airport was because
there was a certain number of council members that believed that we had to do that to stay in relative competition with Dallas. But from that point on, nobody was willing to fund any type of transportation, including buses. So from a transportation standpoint, and right now, infrastructure-wise, the roads in Fort Worth and Tarrant County are the worst I've ever seen them. And the funding for that doesn't exist to bring them back up. I live on the west side of town. We have replaced I-35 North as a real issue traffic-wise almost 24 hours a day now. We only will do a Band-Aid on I-30 that'll start in 2023 and not be completed till 2027. And that will not solve the problem. If you go out in the west side of town right now and look, houses are going up like crazy. And we can't just think about Tarrant County, because we've got to think about what's going on west of our Tarrant County line. And there's a lot of it going on there too. So for us to expect that we're going to come up with the right answer is not, in my opinion, very realistic. So one of the things we'll probably have to do as a board is decide at some point in time, here's the estimate now, do we bump it by 10% just to be good? Because if we don't, you're going to do the same thing we saw on I-35. They redone I-35 and it's still a traffic jam. And that's because they made the predictions and then it grew faster than the road was being built. And the state has taken the position that they will not do public-private partnerships anymore. So that really is going to limit what we can do transportation-wise. So I'm just trying to give you a realistic look at the issue as far as how we're going to scope the size of what we're doing.
I think that's why I mentioned gentrification, because at least we know where it might be headed, so that we can predict a little bit better.
I can tell you one thing, gentrification is happening in every single one of those zip codes, universally without question. There is so much redevelopment going on right now that's changing neighborhood dynamics in revolutionary ways that you're going to see the gentrification element is going to be present in every single one of those zip codes, every one of them. Quantifying that may be difficult because, again, to Zim's point, we've got all the redevelopment projects that result in the gentrification that we have today, not even counting the redevelopment projects that are on the books that are going to further add to gentrification issues in the next 10 years. So it's a big issue.
One of the things, if we can look into that a little bit more, is at least we can predict where we want to buy the real estate to hedge it.
Yeah.
We need to move, and the real estate on the current medical home will go up so that we can build another one. But that's all I'm trying to see is a little bit further out, because we're talking about 30, 40 years from now also as well, so.
DT, we did pretty good on Main Street.
Yep.
I mean, there's a perfect example. I hate to say what the value of that is, what's happening, and look what's gonna happen.
Well, go down
We're
to
not in the
Main,
real
yeah,
estate
go down to
business.
Main Street and try to buy a piece of property. Now,
I'm just
first you
telling
won't
you,
find it. Secondly,
I remember the same conversation we had then. We bought the property on Main Street.
Yep.
I dare say what it's worth.
Yeah.
But I go back to what Trent just said, and I think we're all saying the same thing. Thank God we're in such a great area that's growing, but we got to address the needs for the future of this hospital. When I met Trent, he's in South Lake. I was a young banker in Northeast. Everything's going Northeast Tarrant County. That's where the world's going to move. Now look at Crowley. Look at all the construction down 35. The whole thing. I was in Mike Berry's office the other day working on something. I mean, everybody's developing throughout this entire county. So I agree with Zim, whether it's the Parker County line coming this direction or now all the way to, and I don't want to say things weren't that growing in Crowley and Everman, but look at all the big massive housing developments. Been Kimball, who just did Arlington. He's fixing to redevelop. Trent, you know that probably very well. I know the people he's fixing to develop all the way. Crowley all of a sudden is one of the hottest areas around. So I agree with you, DT. It needs to be addressed. I think it's going to be very hard. I've been a banker 35 years, loaned a lot of money in this market. It's going to be very hard to get it so finite because it's going to keep changing, whether it's political things at the border or whether it's things we don't even know about yet. But again, I
just
totally
wanted
agree
to
with you.
check, we
No,
look at it,
I
and
think
then
it's
we
a
made
great-
an informed decision that Because
Thank you.
otherwise we'll come back and say, do you know the population moving away from that area?
Totally
I said,
agree.
we did it, we predicted, but it was wrong, or at least we looked at it.
Well, and now that we know exactly how we're gonna build them first, second, third on that zero order that Robert's given us, I'm fine. Sorry,
But-
Madam Chair.
No, we look forward to further collaboration with the JPS team as we continue to refine this analysis and bringing back those further recommendations. So thank you.
Thank you.
Daphne, do we have an executive session today?
We do.
We did. We did. Okay, any other questions, sir? Thank you.
Thank you.
Lindsay.
I will tell the board that at our meeting, they had a whole bunch of data that they shared with us that I know Robert made them take it out, but we got a lot more of that specific information.
Good afternoon, board members, Madam Chair. My name is Veronica Murphy. I'm with K Strategies. Katrina Keys sends her well wishes. She is out of town right now, so I told her I'd come and be in support of this meeting and this board meeting. I just want to say that we are very excited to be a part of the JPS bond program. We know that this is going to provide opportunities to grow the capacity of our MWVBEs locally. And we are just working well with the team and, trying to figure everything out and really collaborating and communicating so that we can prepare to have a great bond program. And now I will pass it over to Delon.
So we wanted to be very mindful of the slide count and time, so we have reduced our slides to 50%. So we will talk from this one slide here. I get it. So, once again, my name is DeLon Green. I am the program manager for the MWVBE program. So the Minority, Women, Veteran, Business Enterprise program is integrated throughout the program management process. We are regularly meeting with the JPS Communication Department to develop marketing collateral such as flyers, email campaigns, newsletters, and material for the Yes to JPS website in order to promote bid opportunities and outreach events. We have regular scheduled meetings once a week as a program management team to discuss dashboard items. We want to assure that the information that's been reported on the dashboard reflects the efforts that are being made to accomplish the MWVBE goals. We also have bi-weekly meetings with the JPS diversity team, supplier diversity team, in order to collaborate and coordinate outreach events. The focus of our outreach will be to connect with the community, fully connect with the community, engage them. We have already met with the Arlington Asian Business Council. We have an additional 3 outreach events currently planned. Following these projects, or these particular outreach events that we'll be attending, we'll begin the process of setting up one-on-one meetings between interested contractors as well as with the project management team. We are also reaching out to chambers of commerce and advocacy organizations to set up additional meetings and presentations. As projects are awarded, we will be working also with those prime contractors to host additional bid opportunity outreach events. And are there any questions for us?
Yeah, I do. I was trying to check my calendar on those dates. that you have in October.
Yes, sir.
Are those dates where you're meeting with the groups here or to be at their location?
Okay, so the meeting on the 27th, that will be a virtual meeting. It's with the DFW Minority Supply Development Council. It's a national organization, and they are the local affiliate. They, in addition to being a advocacy organization, they're also a certification organization for MBEs. So that will be at a virtual event. We'll have a panel discussion from different members of the team to discuss the upcoming opportunities, have discussions in terms of where to get certified, where to find out information about upcoming bids, such as the vendor portal, and keeping informed through the Yes to JPS website. On the 28th, that is also a virtual event. That is our kickoff event, or the program management team's kickoff event, to begin to inform the community about what kind of opportunities will be coming forward, as well as being able to meet the program management team and the sources to keep informed. And then on November the 5th, that will be at Will Rogers. It's a multiple organization meeting where we will have a booth to share information with those contractors that may be interested in pursuing work for the JPS bond program.
Okay. Now, the reason I ask that is it's so amazing that you can explain all this in every virtual meeting, and we get amnesia the day afterwards. Trust me. So I wanted to see how, if it's all anyway possible, we could establish a meeting in a facility. We could bring many of the contractors in and kind of walk through these steps to even also make sure they sign in that they got the information. I am willing to offer my church auditorium or chapel for that event. I just know the phone calls I get on a regular basis about the JPS bond program. I just want to bring them to the table, bring them to the room, so maybe they'll quit complaining.
Yes, and we do, that is something definitely that we can discuss with you, because there are organizations that are having in-person events. I think going down the line, we have discussed the possibility of having virtual as well as in-person events. Because, one of the benefits of the virtual events is typically what we found is that you may have more people attending because there's so much construction work going on. There's a competition for, okay, well, what pre-bid meeting, what outreach event am I going to go to? By having it virtual, then that gives them the flexibility to potentially attend all those different events. And so it's definitely a benefit from that standpoint.
Did we traditionally participate in Hispanic chambers?
Contractor
event at Will Rogers? I was there.
Yes, it was a Fort Worth, Expo. It was in early August, and it was hosted, it was hosted by the Regional Hispanic Contractors Association and the Fort Worth Hispanic Chamber.
JPS was there.
Yes, sir. Yes, sir.
So if it's all possible, that after this, we can set a time and meet and discuss.
Yes, sir.
Nope.
It was last week or something like that. So how to prevent that from?
Well, our intentions are so it's a combination of several different things. The kickoff event is to begin to create energy and to allow them to know where can they go to get information, what are the point of contacts. And then from there, you do, like if a contract is being let, You want to have a pre-bid meeting, so you can also give them an additional opportunity. And then you also can do outreaches as, once a prime contractor is awarded, then you can have additional outreach events to allow them to know, contractors to know what opportunities exist.
My concern is those that are sophisticated is not the target for this program. The one that don't have the means, not really good with, email, social media. How do we reach them so that they know there's a kickoff or something like that to start out with, a bigger base? Because those are the hardest people to reach, and that's the one that this program is intended for.
Well, we have a list of approximately 13 different diverse advocacy associations, as well as chambers of commerce here in the Tarrant County area, including, and also the Regional Hispanic Contractors Association, the Regional Black Contractors Association. And what we will begin to do is we're currently in the process of reaching out to them in order to establish presentations and different types of meetings with their members. And I think, based on your concern, that is definitely an avenue to probably help reach a broader audience of potential contractors at all levels.
My concern is, my office is right across from the new Christus headquarters. And everybody that I know that walk by and say, yeah, they only give it to Manhattan, which is out of state, because they occupy a bunch of stuff around our office. And the people within the community, they just say, it just goes to the big guys, and we're not allowed, we don't think we can compete with them, so they kind of pull away from it. It's just trying to get, I don't have an answer, I'm just asking.
I think part of the thing that we have to do is really be clear about JPS's goals on the bond program and what the requirements and procedures are, so people understand that it's clear, and that we communicate those things, and so that they feel comfortable with coming and pursuing work here on the JPS bond program. So we're going to communicate that in through the ways that we do it. We're still going to do social media. We're still going to do email blasts. We're still going to post things on the website. It's just people collect information in different ways. But as long as we're communicating what the procedures are and what's coming down the pipeline multiple times and consistently, I think we'll get the word out.
Charlie.
Can I ask this one question? And we all serve on 1,000 things, and Ralph, I can imagine the questions you get asked, but I'm just sitting here right now, and I'm thinking about Trent, I'm thinking about Robert. It's not about what I do, but I'm on the Fort Worth Chamber, the Fort Worth Metropolitan Black Chamber Commerce Board. I'm also near North Sides, near South Sides Board. So, those three boards cover this. My concern is I get a lot of questions. I've been told in my over 12 years on this board, we don't get involved in this. That's our policy. I remember setting the policy in part of the board. I've sent people to Robert this week. Probably cost you, 45 minutes of your time? I just wouldn't talk to this minority contractor. But in all fairness, I felt bad. I wasn't going to get involved in the conversation. It did me no good. I wasn't the decision maker. I said, I'll get you in touch. I had a situation happen this week on the financial side and the planning side. I said, I know all the people involved, know them personally. I had lunch with them. I don't get involved. Call Trent. And I bet Trent spent some time having to talk to somebody. I wonder if there is a possibility, Robert, I don't know who to send people to. Maybe I've done this. I know but I felt bad. I felt bad because I knew Robert right in the middle of COVID.
And here's why you shouldn't feel bad.
Okay,
because one, I can have a conversation in that case with a community leader. I can understand what their concerns are, whether they're valid or misunderstood. And then unfortunately in this case, or fortunately in this case, a little bit of misunderstanding. Right. God was able to clear that up, and everything went quite well. So that is never a burden to me to deal with concerns when Roger Fisher gets told, well, we want to do this and we want to do that. You all, in my opinion, as board members, should not be put in those positions. As you're going to be. Sure. Ralph Emerson's never going to stop getting phone calls from people because of one, the person he is, and two, the position he's in. But I think it is my role as a CEO to direct them in the proper place or clear it up, and I can do that
But just one suggestion, and just to throw out there, I did this when we built our bank buildings, we had contractors call. We set up like a codaphone. And it was easy to say, you know, if you got any questions about JPS, whether it's bonds or financial, or who's gonna get the bond business, who's gonna build the contractor, a minority contractor wants to know how to get in touch with people. Maybe we had a designated line that we could tell people, call this and leave what you want.
Sure.
And then, because you've got qualified people that you can give it to in construction or in consult, you can maybe have some of those people call back. I just feel bad about you having.
Well, and we try, here's part of the challenge, in all honesty, Charlie, and I think you know this. We try to do, and we're advancing as much as possible the website and making sure that every question gets answered, especially questions from a potential vendor, that all vendors get that question and all vendors get that answer. Challenge is when y'all get called, they probably might have heard the answer, but they don't really like that answer.
Right.
So they want to move it to another level. So I think even a phone call or a number doesn't really help. And you almost have to have, so I look at it as a caseworker, it's touch to touch, it's hand to hand.
Well,
So
I feel bad about just telling them to call you.
Don't feel
because
bad about it.
You get
It's-
tied down.
I just
Okay.
send them to Suzanne anyway, so
I
it's all
appreciate it.
works. It all is just fine.
That's what
And
we'll continue
she
to do.
scares me, she scares them, so it
Best
works
thing
out
is
really
I
well.
stayed out of it. That was the number one.
So anyway, sorry, Madam Chair.
That's
but-
okay.
Thank you, Madam
That's
Chair.
Thank
okay.
y'all, that was hugely helpful, and I think board and me are very appreciative of what y'all are trying to do, and I think that slide will be forced to be a 3-slide in the future, because you'll have many more activities and
Yeah.
many more things y'all are doing, and we're grateful for it, because y'all are representing not only the broadest levis aspect of this, but JPS and what we're trying to do, and I think that's good. So thank y'all very, very much.
Thank you.
I think on Charlie's suggestion on the phone line.
Yes, ma'am.
I know it has to be answered. One of the benefits of that is you can trend the types of calls that you are getting and get some answers and get that out there on a website so folks can know this is what it is. So I know it's a lot of trouble, but sometimes when you get the same question here, there, and they all are the same, if we could say, this is the answer, because that's what most companies are doing. For this question, here are your answers. So,
Well, I appreciate you taking the time, Robert.
You bet, Charlie, not a problem.
yeah.
If I can just make one other comment, be very candid, just based on my conversations and discussions in the community. One of the problems is that many times, many of the contractors know, but want to call Ralph or Charlie, because Charlie's really respected in the community with these contractors. And they want to call because they know we're on JPS board. And what they're seeking is for us to help them get by the rule.
Right.
They haven't complied. They want to find another way to get certified when they're not in compliance. And that is really what's tough out there. And that's why I asked for that kind of public meeting or something, because I need to be in the meeting face up. You know, because hey, I got a call just yesterday, and there are some persons who call me, I don't even bring it here. I just deal with it myself, you know, because that problem is out there.
It is. And Ralph, there are questions out there. I was at a meeting, somebody came up and started saying, well, y'all have made this decision. I said, that's not true. Where'd you get that from? And I said, so if you don't hear it coming from these sources, that is not true. And I said, but where did you get it from? And they'd just been out there reading the Blue Ribbon panel and made the decision that that's what we were doing. And I said, well, thank you, that's a good idea, but that is not where we are. So I get that. So, but I do think that I try to be careful to know where to refer it to and get out of it as fast as I can.
Well, I'm going to follow Steve's lead. Send him to Robert.
Yep.
He does.
Yes, DT.
I think we talked about this before, but I'm not sure how we can do this. We were talking about, there's a lot of stuff that we can learn through this process to help the minority get awarded. Is there a way that we talk about tracking them so that we can learn for many years to come how many got awarded, how long do they stay in the program? Do they graduate from it and then sponsor the next group coming in? So that is a big brother, big sisters helping another group as they do really well under this program, because we don't want them to be a career into this program. So have we make any headway there?
Well, that'll be part of the items that are the matrix that will be displayed on the dashboard. So we'll be tracking overall participation, number of MWVBs that have been awarded contracts. Then there is a screen to drill down to look at each individual project or contract and look at what is that particular participation on that contract.
It's like when they create jobs and make it to the next level, we should applaud them and then make that into an example to teach another group coming in.
Right.
So that can be kind of a changing direction, change way of life, changing life also. So.
That's what everyone's doing right now.
Any other questions? Thank you very, very much for the update. Really appreciate it. Okay.
I will tell you, Madam Chair, that you can't, and I know the board knows this, but I think it needs to be emphasized, you can't do a project like this bond program and coordinate all this unless you have a strong chief operating officer. Because so many of these meetings come from Karen and Karen's office. And to think of the orchestration that goes on in this, it's immense. You got a lot of moving parts. And in addition to that, with Lauren Poe and Zelia from the mental health side, and Sharon from the financial side, and Mark from the innovation standpoint, JPS and DT mentioned it the other day, the executive team is really coinciding with this. This bond package takes a lot. And so credit to Karen and credit to the members that I just mentioned on the executive team, because if you don't have somebody like Mark thinking out of the box for new and different things, if you don't have Sharon with the financial checkpoint, if you don't have Karen orchestrating it, and Zelia from the mental health, and Joy from the community health side, you'll make big mistakes. And then the other person, and he won't appreciate this at all, but when you got a board member like Trent is hugely helpful in this, because Trent will constantly tell me, well, you got to watch out for this, you got to watch out for that. I was on a project 5 years ago, and here's how it went wrong. And he's been in the trenches of this, so I really want to tell y'all as a board, you've got a really good team of people, aside from the Broadest Levis team, which I'm proud to work with them, but internally, you really do have a good team, and I'm thankful for them. And Karen scares me too, so I want to make sure.
Okay, so you want to make sure,
I want to
okay.
make sure you
All
know
right.
that.
Okay, well, now we're at item 12, the consent agenda. Are there any items that anyone would like pulled from the consent agenda? Okay. If there are no items to be removed from the consent agenda, can I get a motion for approval of the consent agenda? Okay, Ralph, okay, Ralph and Amanda. All those in favor of the agenda signify by saying aye. And those opposed by nay. Okay? Now, do you have a report open?
I do not have a report for open. I have some updates for you for the closed session.
All right, okay. So at this time, we can close the open session, and then we will go into closed session. I guess everybody might need about 5 minutes. That's all you can get. So we'll be back in 5 minutes. So that'll be 3:20. would be under 14C, privilege, okay?
Request approval of the medical staff credentialing activity as discussed in closed session.
Second.
To approve? Second.
All right, I have no
Zim.
idea who did the first.
Zim and Steve.
Steve, okay.
Zim with the first motion.
Until they ready to
Montgomery
go.
with the second.
All those in favor of approval of the privilege signify by saying aye.
Aye.
All those opposed by nay. Motion passes. There being no further business.